دكتور نبيل احمد من القاهره، خريج القصر العيني سنه 95. من سنه 97 ل 2000 كان بيدياتريك انكولوجي في ناشونال كانسر انستيتيوت جامعه القاهره، ثم من سنه 2000 ل 2003 بيدياتريك ريزيدنت وتشيف ريزيدنت في كورنيل ماونت سيناي. 2003 2006 فيلو اند تشيف فيلو بيدياتريك هيماتولوجي اند انكولوجي اند بيلر كولج اوف ميديسن. 2006 لغايه دلوقتي اسيستنت بروفيسور اوف pediatric hematology and oncology, and his practice is mainly 25% about bone marrow transplantation, hematology and oncology. 75% من البراكتس بتاع دكتور نبيل عبارة عن cell survey toward brain tumor mainly research. بنرحب بالدكتور نبيل.
خليك براحتك خليك براحتك.
دكتور نبيل هيتكلم معانا على الانتي بايوثيرابي.
نيوتروبينيا.
صباح الخير، احب اشكركم جدا على شرف دعوتي. ABCDE شامل كل الجامعه نظيفه، اشكركم جدا، ده شرف كبير. هتكلم الاول، انا هتكلم على الانيميا الاول بس عشان اوصل باللي هشام اتكلم عليه. هتكلم على فيبرال نيوتروبينيا. احب ابدا اعرف احنا فين، قد ايه منكم طلبه طب؟ يعني الاغلبيه. في حد بوست جراديويت او اوريدي اطفال؟ طيب انا زي ما عملت مع هشام، لو سمحتوا وقفوني في النص. انا هقول لكم الستاندرد اوف كير من وجهه نظرنا. كل حاجه طبعا الواحد لازم يقيفها حسب المكان اللي هو بيشتغل فيه، وده مش حاجه غلط. ما ينفعش نمشي عمياني ورا امريكا عشان هي امريكا، لان دايما اللي بينفع لنا هو اللي بيدفع لنا. مظبوط، هو احسن حاجه. I'll talk about febrile neutropenia, which is a pediatric emergency. Children with cancer are surviving, and this is why pediatricians are seeing them. And it is very appropriate and very important for a pediatrician to know what to do when they encounter a patient with febrile neutropenia, because the difference is huge. A patient who's treated promptly and appropriately after high-dose chemotherapy has 96% chance of surviving this attack. It increases up to 40%, 40%, almost half of them could die with inappropriate management. And it's a very simple concept. I'll be talking about the why, when, and how to use empiric antibiotics in oncology and hematology patients. These are the names of my colleagues who put this together. This is part of a course we give to our fellows, pediatricians going into Texas Children's Cancer Center to become pediatric hematologists, oncologists. A little bit above what you expect to see, but it's all simple concepts. يعني Egyptians are by average smarter than usual human beings. Can anybody tell me what empiric is? The word empiric. Empiric.
Educated guess.
Educated guess. أقرب كلمة ليها بالعربي اعتباطي, but educated guess is exactly what it is. It could be evidence-based, but it is not data-based. It's not immediately based on what you find in the patient. So we used lots of data, lots of studies done in the National Cancer Institute in the United States, in Washington, D.C., and built a big empiric, educated guess protocol for dealing with these patients. We define febrile neutropenia as a fever, which is might be the first manifestation of this very life-threatening, because patients look fine when they come to you. We should really consider it as a very serious event. A patient who has an immune system that is intact can withstand 48 hours of evaluation without intervention. So if you have a patient who comes to the emergency room, not very sick, has a fever, you have 48 hours to find out what's going on. Unless this is a neonate. A neonate is equivalent to a febrile neutropenic patient. With febrile neutropenic patients, you have to act blindly, empirically. We define fever as a single temperature that is more than 101 Fahrenheit, which is 38.3 degrees centigrade. The old days we used to say if you measure it axillary way because it's less infection, or through the ear, you add half a degree. We do not do this anymore. If you record 38.3 or more, this patient has fever. We do not do absolute rectal temperatures. It's a culture in oncologists. We never introduce thermometers in patients' bottoms. If a patient has a lower fever, so 100.4, which is equivalent to about 38, 37.9, if this repeats after 1 hour, this patient is febrile and then gets classified as febrile neutropenic. Of course, you have to use whatever is intuitive. You have to use al-Kayasa. If you're Kayas and Fatan, you have to understand if a patient looks sick and does not have a fever, this patient is sick, so this patient is febrile neutropenic. So you do not discharge somebody because they do not have a fever. This is very important because leukemia patients are about 2/3 of the patients with cancer we see, children with cancer. These patients get what we call induction, intensified therapy for about a week. We do not keep them in the hospital. We send them back to their pediatricians, and they come back again for a very intensified month. We don't have a business in the hospital for the whole month. So you see them. A lot of them are on dexamethasone and prednisone, and these are very good antipyretics. So they will come to you looking sick. They have neutropenia. They're very sick. They're febrile neutropenic, but you could discharge them because they do not have a fever. They do have a fever, but the steroids are masking these. So very important questions: are you on dexamethasone? Are you on prednisone? Okay. If they are, you look at them and consider them as febrile neutropenic. Neutropenia is a very interesting. It has been back and forth. What is the cutoff for neutropenia? So a normal neutrophil count is between 40 and 60% of your peripheral blood count of white blood cells. So anybody who has about 1,500 or more neutrophils is considered normal. And neutropenia by the pediatrics text, which is defined as 1,500 per microliter or less. It's mild if it's 500 to 1,000, it's moderate from 200 to 500, and it's considered severe if it's less than 200. Data shows that patients who have less than 100 neutrophils per microliter of their peripheral blood are profoundly neutropenic, are at a substantially high risk of dying from this infection. So you have to treat them very, very differently. If you do a blood count with differential white blood cell count, if somebody has a white blood cell count, a neutrophil count of 50, this patient gets admitted, gets treated very, very aggressively, because the data shows that these patients will collapse if you do not treat them aggressively. For practical reasons, a patient who has 500 or more is considered okay. So for a pediatrician, 1,500 or less, it raises red flags. For a pediatric oncologist, 500 or more is a good number, because we live with less, yes. 500 or more, you are able to take care of a serious infection if you have 500 or more. It's very important here to consider the race difference. We consider ourselves as one population. We're a merge of 3 continents, looks like. We have very diverse backgrounds. Patients who are from the south of Egypt kind of have an African race in them. They could be fine with about 300 count or less. A lot of the African Americans run with 1,000 or less, 800. And these patients are very, very healthy for the rest of their lives, pre-chemotherapy. Okay, so neutropenia can be defined. Some of the Asian races as well have lower count at baseline. The risk, if I ask you what is the biggest word of last century from 1900 to 1999, it's relative. This is the biggest word we've learned in the last 100 years. Everything is relative to each other. White is white relative to darker colors. So neutropenia is the same. It's all relative. Somebody who has a neutrophil count of 100 or less is relatively very different from somebody who has 1,200. Both of them are categorized as neutropenic. So the depth of neutropenia is very important, as well as the duration of neutropenia. The longer you are neutropenic, the more you are susceptible to opportunistic infections. This is why we diagnose patients with, what we call benign neutropenia. They come, they're benign for 1, 2, 3 weeks. Afterwards, it's dangerous. We start panicking, we start looking for immunotherapy, we start looking for what are potential donors for bone marrow transplantation, because we live in a very hostile environment, anywhere, even in the cleanest environments. We live amongst fungus. We take care of them because we have neutrophils. Everywhere there is fungus. If you have 3 weeks without neutrophil count, you get colonized and it's simply lethal. So the length of neutropenia is very important. When it comes to oncology, the magic number is 7 days. 7 days or less, 7 days or more. Patients who are more than 7 days have probably had problems, have probably had counts on the surfaces of bacteria and fungi. So we consider them at more risk. And it is shown by evidence-based, large numbers again of patients who are neutropenic and febrile. If they have been neutropenic for only 6 days, they are much less risk than 8 days and more, and 7 is the cutoff. Sites of infection. Can somebody volunteer? Where would you think the infection is coming from in a neutropenic patient? A patient was diagnosed with leukemia, gotten high-dose chemotherapy, became neutropenic. Where do you think the bacteria comes from? Yes, no, nothing is wrong. It's enteric. Basically, we have barriers. We have barriers that are like, Haras al-Hudud. They do not allow people to come in. Once there is a breach, anything can come in. So these patients get chemotherapy. The major side effect is enteritis, small intestinal inflammation. The barrier gets broken. These patients are infecting themselves from inside. This is most common thing. Okay? So blood is very important, but really blood gets it from within. Mucous membranes, upper and lower respiratory tract, urinary tract, and gastrointestinal. A very important thing that happened over the last 15 years is we do not stick patients, we do not puncture the skin anymore. If you go to the cancer hospital, National Cancer Institute, everybody is putting central lines. We're looking at the quality of life now. We put indwelling catheters with patients. We put portacath, which sits under the skin. This is hardware. Hardware cannot be recycled. We are a very recyclable body. Our molecules get thrown depending on the place, between every hour to every 3 months. Even in the most stable cell in our body. If you put a piece of plastic, the body cannot recycle it. So this is a very good medium for colonization, and mostly gram-positive cocci. The types of infection by frequency is, as usual, number 1 is the viral, but what isolates are bacterial, atypical bacteria, viral, fungal, and parasitic infections. And of course, this changes with the locality where the hospital you were. you need to have a directed history. It's a very short time. At Texas Children's, we've been optimizing when do you need to give the antibiotics in. And we did, as others, different institutions decided, do you treat everybody who comes into the door, or do you wait until you have some evidence? And we've decided that you really need to treat them as soon as you see them. But 4 hours has been the magic number again. We found large numbers of patients, if they have received an antibiotic injection, first antibiotic injection, 4 hours after they have developed fever, they are more at risk of becoming hemodynamically deconditioned, more at risk of going into the ICU. So we've decided very simply that if you shake hands with a patient who is known to be neutropenic, or even tells you about something that could make him neutropenic, like I've received chemotherapy 3 days ago or 5 days ago, you give them antibiotics even before you do anything. Okay? So we've been doing ceftriaxone. Everybody who comes in through the door with a fever, a history of being a cancer patient, having gotten chemotherapy or anything, we give them a dose of ceftriaxone and then we start talking to them. At least this patient will not collapse within the next 4 hours, because we always complain about waiting. Waiting is the biggest issue in the United States. Patients stay between 4 and 16 hours waiting to be seen by a doctor. So believe it or not, we've been able to kind of triage patients with cancer to be seen within 2 hours. So still, it's a very long time. You need to know when the fever of the patient started. The most important, the highest heal with this, in this scenario, is a good history, good directed history. When did you get your fever? Because you want to know, do I give him the ceftriaxone right now or wait for the nurse to see him? You know, the last chemotherapy has something called the nadir. Most of the chemotherapeutic agents do not drop the count right away. They take 3 days to drop the count. It bottoms at 7 days, recovers between 2 and 3 weeks. This is why every patient with cancer goes to take a dose of chemotherapy every 3 weeks, because this is the time that it bottoms out in a week and then starts to recover within another week, goes back to normal within a third week. And this is why we cycle around 3 weeks. So if a patient has gotten chemotherapy 2.5 weeks ago, this patient is probably recovering, kind of probably less risk than somebody who's gotten chemotherapy 3 days ago. Have they been exposed to somebody? Have they had any procedure? Patient who's just gotten a line put in, comes in with fever, and we do this. We do kind of aggressive things. We put the line and give them the chemotherapy the same day. They come back in 3 days to the emergency room. These patients have gotten their counts just dropped. They're probably high risk, but they've also gotten some hardware in. We start thinking of the organism that causes this, which would probably be more gram-positive cocci or something. Next, we do prompt prompt movements, careful and repeated exam. We pay particular attention. There is nowhere in medicine a very good exam, very detailed exam, and almost paranoid is more fruitful as a febrile neutropenic patients. These patients don't come in with big patches of red skin. These patients come in with a very subtle color, and it's underneath it is a huge cellulitis. So you have to be very, very careful. Patients have to be stripped bare completely, looked at all over, and these are kids, so they do not direct you to where you need to look. Particular places are lines, procedure sites like lumbar puncture, the sinuses, you press in the sinuses, the oropharynx, very simple medicine. You listen to the lungs, the abdomen, and on the bottom. Again, we do not do any rectal things in neutropenic patients. Never do a rectal exam, never put a thermometer, never put a scope. It's very dangerous. Anybody have, what's the complication, what happens? In almost 80% of these patients, if you cause a mucosal break, they get something called polyphlebic thrombosis. Nobody hears of it anymore. It's an acute thrombosis of the portal vein. It's almost lethal. So we do not do this anymore. We even advise the patients not to do this when their counts are fine, because it's a culture. If the mother is used to taking the temperature by the rectum, she will do it at home. You know, if we tell her that this is haram, you cannot do this anymore, it will be a culture that I cannot do this in any condition. So again, we obtain the initial labs, and it's very simple. You obtain a blood culture. Most of the antibiotics will not affect blood cultures if they're taken almost simultaneously. Now they have the new systems. Cairo University has it. The National Cancer Institute. It's a Bactic system. It's an automated system, and it has an absorbent constituent, absorbent granule. So it actually sequesters the antibiotics in the blood that you inject. So even if a patient is on antibiotics, they can still grow the bacteria. And we have quite advanced systems actually there. Other things that are very, could be, I mean, they're very subtle. Nobody has shown C-reactive protein is extremely useful when you have a patient who's collapsed without neutropenia. It's so and so. Plus, people have shown both ways, that it's useless and not useless. If it's extremely high, it's associated with high risk. Chest X-ray has been shown by working from LA to be important only if you find something. So if you're a good clinician, and most of people trained in Egypt are very good clinicians, listen. If you do not find something, most probably you do not need to do an X-ray. It's almost always useless. Patients who are not making sense, acting funny, need to have a lumbar puncture because you always suspect the brain. And anywhere in the world, it's not when you're in a developing country, but in a lot of these patients you find parasites. So simple stool culture. Use common sense. If the patient is oozing something, it needs to be cultured. The most important change over the last 40 years has been this word empiric antibiotics, treating the patients without even having a clue what is going on. It's the cornerstone of our therapy, and we do it religiously. We would like to do this within 1 hour. 4 hours is when you're too delayed. This includes when the patient had fever at home. The patient had fever at 9 a.m., comes to you at noon. You need to give it before it's 1 p.m. And the data is extremely compelling. There are choices, mix and match. It's very simple. What kills the patient is not a gram-positive organism, except one, and I'll mention it a little later. What kills the patient is gram-negative rods. So our therapy is always centered at gram-negative rods. Broad spectrum, ceftriaxone, ceftazidime, any broad spectrum third generation. You always know, of course, that first generation, second generation, third and fourth generation now, cephalosporins, they're very low side effects antibiotics. But we started with first generation. These were very heavy gram-positive antibiotics. We use them for wound infections. You go to second generation, you have more positive, you have same positive with a little bit more negative. You go to third generation, we're starting to talk about good coverage for gram-negative rods. So, simply, a second generation cephalosporin for a febrile neutropenic patient is not correct. Third generation is the minimum you have to give. A third generation cephalosporin. So, ceftriaxone, ceftazidime, cefotaxime, depending on what is available. And they're almost equally efficacious. We choose the empiric therapy based on different things. So again, the baseline is gram-positive cocci are very common, but they will not kill the patient. So we would rather treat something that is less common but more lethal. These patients die within minutes. And particularly you have to take care of the patient is sick, you give the antibiotics, they start getting a little bit sicker at the beginning because of the release of endotoxins. We choose the antibiotic therapy depending on the isolates. If you go to a hospital, this data is there. The microbiology department has it, they all have it, but they don't share it. We don't ask. We think that they should give us the name of the organism, or not even care about the organism, because we use multiple antibiotics. The best thing you can do is to know what grows in your institution. We all carry microorganisms around us. We give them to the patients. The cleanest of us give them to the patient's back. Every institution grows a certain pattern, and the pattern is very reproducible. So once you know this, if I know that I have a problem with Staphylococcus epidermidis, I will be focused on covering this up front, because 60% of my isolates are like this. So the susceptibility pattern comes next, which also is institution-based. You ask the patient what are they allergic to, and you eliminate this. and an organ dysfunction, we always like to give aminoglycosides, that it's safer. They don't work on their own, so you cannot give amikacin on its own. It's one of the best coverage for gram-negative rods, but it has to work with something. It doesn't have a spine. It has a very good specificity, but it has to come with a third-generation cephalosporin. But sometimes we are very limited when a patient has a renal problem, because you do not want to induce acute renal failure in these patients. So what we do, we move on to the further down. We go to a fourth-generation cephalosporin, and then we do not need amikacin. And of course, you direct it at your exam. Like I said, exam is the central point of this. We do risk assessment, and I'll speak about this in a little bit, so I'll not duplicate and I'll move on. I'll tell you just, not for you to learn this, you don't have to learn this, but this is the type of data you need to know from your microbiology department. TCH is Texas Children's Hospital. This is where I work. In 2007, we do this every 5 years. So we just did this year, and in 2007, I have the data from this. We reviewed 167 isolates. So this probably is about 40% of the patients, because this is how much we grow. If we have 100 patients, 40 of them will get an isolate from the blood. And we found that coagulase negative staphylococcus and staph epidermidis is about 40%. So this goes with the whole world. The whole world is moving. Let me go back. In 1960, 1970, most hospital-acquired infections were Pseudomonas, Klebsiella, the bad gram-negative organisms. This has changed, and it has changed because of two things. It has changed from being gram-negative, dangerous, into gram-positive and less dangerous. And two things, if you look at the history, have happened since over the last 40 years. Number one is giving prophylactic antibiotics. We send our patients home on prophylactic antibiotics, and these prophylactic antibiotics suppress gram-negative rods. So when these patients get infected, they get infected with gram-positive cocci. The second is putting hardware. Like I said, we put lines, and these lines get colonized, and this is why it has almost all over the world, except in areas that are not very sophisticated. If you look at some provinces in China, they still have 80% gram-negative rods, because they don't use central lines, and they don't have facilities to use prophylactic antibiotics. If you go to the National Cancer Institute, the pattern looks exactly like this. They're using prophylactic antibiotics, and they're using central lines. So, between the first and the second number, we have 56% cons, coagulase negative staph, and alpha hemolytic strep, and then the next entities are much less common. Coagulase negative staphylococcus is our first thing, so this has kind of prompted us to use the regimen I'll show you in a little bit. Again, it takes about 5 people to make, it takes 2 people to make a team, and it takes about 5 people to make a team that can give you sound recommendations for what antibiotics to use. So we got these people together, and we looked at evidence-based clinical decision supporting for our neutropenic patients. And this is the hospital, and it's 5 buildings of these. By the way, this is the biggest pediatric hospital in the world. Who knows what is the biggest children's cancer hospital in the world is? Our hospital here is a huge pride. This is the biggest, by 25 beds, the biggest children's cancer hospital in the world. And they're making 300 more beds. St. Jude's, which is kind of the most famous, has 130 beds. They have 185 beds here, and they're making 300 more. So, and it's 2 standard. This is a very high standard hospital. So, like I said, we risk assess patients. Not every febrile neutropenic is the same. Patients who come in shock, looking sick, have a focal infection, as I mentioned, have a very low count. We call them profound neutropenics. They're considered high risk. With those are the patients who have bad treatment cancers. Some of the cancers we have to treat very, very intensely. Acute myelogenous AML, acute myelogenous leukemia. We wipe out the immune system of these patients because the disease is very aggressive. Patients who have just been diagnosed with acute lymphoblastic leukemia, particularly because they are on dexamethasone, it's an amazingly immunosuppressive medication. If the patient does not have any of these things, they're considered low risk. And the low risk can almost be discharged home. We've shown a very nice history. I was a trainee in the National Cancer Institute who made a very big study. It was published and presented multiple times in the United States, that you can actually see these patients, give them one shot of ceftriaxone and amikacin. The whole dose, the 24-hour dose of ceftriaxone and the whole dose of amikacin. If they are not high risk, you can do this, send them home and see them in the clinic. It was very, very nice data. So we would use monotherapy otherwise. We can use ceftazidime. The National Cancer Institute in the United States has shown that you can use this drug, ceftazidime. I think it's clavuran. Is it right? Clavuran, ceftazidime, I'm not sure. You can use this as a single agent. You don't have to add anything else. Mortality is not high, and it is centered around gram-negative rods. So you're safe, and you have some gram-positive coverage. If the hospital is like our hospital, has a lot of gram-positive cocci, vancomycin gets added early on. In this scenario, for instance, this combination, you should not be very rigid in what you use. You should know the science behind it. What does your antibiotic cover? But learn one combination very well. Like, you have to use one tool exceptionally well, but also have others in your pocket in case you cannot use this. You have other alternatives. So piperacillin tazobactam is a broad-spectrum antibiotic like augmentin, and vancomycin. They make a very nice combination. If a patient comes in high risk, we add to this gentamicin. And this has been the recommendations all over the world now, unless the pattern of the hospital is unusual. Vancomycin has been one of the medications that multiple hospitals are controlling now because of the resistance. The problem is when you get a methicillin-resistant MRSA, I hope you know this word, methicillin-resistant Staph aureus, the big gun is vancomycin. And we've been using vancomycin, but the problem is, if you look at bacteria, they develop a strategy every 10 to 20 years. Bacteria are becoming now VRE, vancomycin-resistant enterococci. So what do? You cannot let the patient, decompensate, and you cannot use it with everybody, because once you get a vancomycin-resistant strain all over the hospital, it is very, very difficult to deal with. So we've been tightly controlling vancomycin. And tight control means you can start as you wish, but we call it the vancomycin police. An infectious disease physician teams up with a pharmacist and they police everybody. If you have used it for 48 hours or more, they come to you, they don't arrest you, but they hold you responsible while using it after 48 hours. If you don't have a good reason, like an isolate, or patient is very sick, or patient is in the ICU, or patient has an infected line, or patient has an abscess, you have to stop it. And trust me, not even the president can change this. It is extremely tight. And this is why the vancomycin resistance has been kept very, very low for the last 15 or 20 years. So there is nothing like you cannot use an antibiotic. You can use whatever you think is justified, but you really have to be very responsible, because what would anybody use to treat a middle ear infection in a otitis media in a child? 3-year-old healthy child, middle ear infection. Any suggestions? Sorry? This is the proper thing, but most of these patients use augmentin, and you have huge amoxicillin resistance because of this, because it's used right and left. We have to be very, very smart about our choices, because it doesn't hurt you now; it hurts the whole community. So, really, you're not done yet. Putting the patient in is the big risk control, but patients are expected to get sicker within the next 24 hours. Like I said, particularly if they have a gram-negative rod infection. The good news is if you're a busy resident or a busy intern, first-year resident, you can take care of this. You can, the smart thing, you have to prioritize your patients according to how sick they are. Patients with febrile neutropenia, even high risk, if they're going to act bad, misbehave, get sick or die, they will do this within about 24 hours. I want to tell you one exception for the good gram-positives that don't kill. It is alpha hemolytic streptococci. They are as bad as gram-negatives. You can discharge the patients if they've been fine, if they've been at low risk, afebrile for 24 hours, had negative cultures for 48 hours, if they have had a count, and when we know some, we get scared, but when we know more, we get more comfortable. So 100 is a very low number, but we discharge patients with 120, although this is severe neutropenia, only if the counts are coming back. So you always have to look at the trend. Where is the curve going? Is this patient recovering the count? He was 0 yesterday, the day before he was the day before 0, yesterday he was 80, today he's 120, tomorrow he'll probably be 480 or 500. So when they're kind of recovering, this is when you think of discharging them. Two important things, and I will not go into details because you're not specialists, but this is what you need to do. You look at the cultures. Most of the cultures will come back positive within 48 hours. 85% will come back positive within the first 24 hours. The rest, almost 99%, will come within 48 hours, and then you're almost always treating, empirically. If the patients are febrile after having used all your wits for 5 days, you start thinking empiric antifungals, and this is for the specialist. If they go on 10 days, you start thinking of a viral infection, etc., etc. Again, it's all empiric. And make sure you communicate back with the institution of the patient, where the patient belongs. Because the safest is to stabilize these patients and send them centrally to a cancer center, because this is the safest. This happens everywhere. So we should not try to become cowboys, try to treat things in our hospital without being specialized. I think I will stop here. The rest of this is kind of very, very specialized, and I'll take questions. Thank you very much for your attention.
Time for questions.
Regarding the fever and the neutropenia, would you like to add antifungal medications, empiric or no?
On the 5th day, day 5 of hospitalization, if you do not have any response or evidence of an organism, you can add antifungals, broad spectrum antifungals, and this is amphotericin B.
Fluconazole.
Fluconazole can be added as an adjunct, not as an empiric antifungal. You have to have a very broad spectrum, so we usually use
amphotericin.
Because fluconazole is very narrow spectrum.
أسئلة تاني؟
تفضل.
بالنسبة للنيوتروبينيا شلون للبلاد ترانسفيوجن بدل الانتيبيوتيك؟
Do you mean blood transfusion or white blood cell transfusion? You mean white blood cell transfusion? Yes and no. So some people have shown that you can transfuse granulocytes, which is a buffy coat from a donor. There has not been convincing data that this works or improves the survival. It only improves the survival if patients have an active site of infection. So a patient has an abscess, and you know that there is no boundaries to contain this abscess, you can give them neutrophils. The other thing is if they have fungal infection, clinically documented fungal infection.
choline-stimulating factor?
Of course, choline-stimulating factor, on the other hand, has been shown to shorten the period of neutropenia and thereby decrease the risk period. Nobody has shown that they change the outcome, so the mortality of patients, but definitely they have been shown to substantially decrease the neutropenia period and maybe indirectly decrease the risk.
If I may add something, I'm an adult hematologist oncologist, and just to answer your question about granulocyte transfusion, I'm an adult hematologist oncologist, and to just kind of add to the granulocyte comment, granulocyte transfusion is very difficult. I remember, like in 15 years, I had to do it once, and it's because it can induce a lot of reactions. It's actually almost impossible to do. And even the one patient that had a fungal infection was in the ICU, crashing. We still could not do it in time before, obviously that patient died. So I don't know if your experience is the same in pediatric oncology, or do you use granulocyte infusions more often?
We use it a little bit more often, this particularly because I work in the bone marrow transplantation unit.
Right.
But again, it's almost as a belief.
Yeah.
There is no clinical evidence that would push you to do it routinely. It's extremely difficult. Patients, the donors have to be pheresed, which is a huge deal. Having somebody sit on a pheresis machine for 4 or 5 hours is not very easy to do.
نشكر دكتور نبيل أحمد. Next speaker is Dr. Talia.